Going to start talking again. People can come back and finish their tea and snacks. I'm Ross Blank again. I'm a surgical intensivist. I'm an anesthesiologist. I'm not a surgeon, so I'm not somebody who cannulates patients for ECMO, but I take care of a lot of ECMO patients in the ICU after they've been cannulated by my colleagues. I've been certified in ECMO management by a ELSO course, which is run in the United States. I did that before we had our own course at University of Michigan, but conveniently ELSO is based, its international headquarters in Ann Arbor, Michigan, because it was founded by Robert Bartlett, really the godfather of ECMO, who was faculty at Michigan for many decades, and the former director of the surgical ICU, where I am currently the co-director. So I'm going to talk about ECMO in terms of why we put patients on ECMO in the context of ARDS. I'm not going to talk in any detail about ECPR or VA ECMO in this talk. I'm going to talk about some of the different configurations of ECMO cannulas, the pros and cons of those configurations. And then in the second half of this session, I'll talk more about the clinical evidence for using ECMO in respiratory failure. I want to give an official thank you to several of my colleagues from University of Michigan who are not here with me in India. Several of my colleagues are here, but we have many of our colleagues who prepare educational materials on ECMO, including my fellow anesthesiologist, Michael Stentz, surgeons, Lena Napolitano and Stacy Aubrey. I've adapted several of their slides for this talk for all of you and want to give them appropriate credit. Here is a graph from ELSO, which is the Extracorporeal Life Support Organization, showing the numbers of ECMO over the years internationally. There is a ongoing ELSO registry of all ECMO cases for all indications, and you see here that through the 1990s there was a pretty stable low level of ECMO around the world, and then there was a inflection point right around 2009, 2010, which increased steadily and reached its maximum in 2020. So what do we think the cause of the inflection point around 2009 was? Any guesses? H1N1. So it was a combination of H1N1, a respiratory viral epidemic, pandemic, combined also with some emerging data from what's called the CESAR trial, showing the potential benefit of ECMO in ARDS. And there was a clear uptick there. And you see the peak was 2020, which corresponds to yet another international respiratory virus pandemic, COVID-19. And we've maintained pretty high levels since then. This is not only ARDS, but that is a big part of the driver overall. All right. So let's talk about why would we use ECMO in respiratory failure. The first published report goes as far back as 1972 in California, and this was a trauma patient who, you can see the abstract here from the New England Journal of Medicine, a 24-year-old with a transection of the aorta and multiple orthopedic injuries, who had surgery to fix the transected aorta, had surgery for orthopedics, but was developing worsening respiratory failure in the ICU. The original lung was called the Bramson membrane heart-lung machine. He was continued for 3 days plus on this machine with a flow rate of 3 to 3.6 liters per minute. And they don't go clearly into the indications, but they tell you in this abstract that his oxygen tension, his PO2, increased from 38, which is dangerously low, to 75, which is safe. So severe hypoxemia was clearly part of the indication. As well, they decreased the oxygen concentration from 100% to 60%, so spared the overt oxygen toxicity. And they also decreased the peak airway pressure from 60 centimeters to 35 centimeters of water. So the very high vent settings, the very severe hypoxemia, the very high oxygen requirement, all were mitigated by this extracorporeal strategy. And this patient survived. So in general, what are the indications for ECMO and ARDS? Here are some possible answers. I've mentioned severe hypoxemia. Severe hypercarbia can be an indication in and of itself. It's much less common. We do have some situations where you have a patient with severe status asthmaticus or severe obstructive lung disease who has a respiratory acidemia, which is not treatable by other means. But usually that is treatable by other means with tolerating hypercarbia, treating acidemia with alkali therapy, etc. Avoiding injurious ventilator settings, oxygen toxicity, giving the lungs more time to heal, because ECMO is not directly healing the lung or treating the lung, it's supporting the lung with a artificial lung while it has a chance to heal. And in some situations, either chronic or acute on chronic, ECMO can be a bridge to lung transplant. So the correct answer here is F, all of the above. All of these can be together or separately indications for ECMO support in respiratory failure acutely. Physiologically, Steve touched on some of these points in his talk. I'm going to reiterate them because they're important. We always have to remember, what does ECMO do and what does ECMO not do? Why would we don't want to just say, oh, this patient is really sick, let's do ECMO. We want to say this patient is sick for this reason, and what can ECMO provide that we can't provide by other means? We have the ability to immediately increase global oxygen delivery because of the oxygenator and the blood flow, and we control that, as Steve said clearly, by adjusting the speed and the flow on the pumps that we use. We can also directly affect CO2 removal by titrating the sweep gas, which goes through the oxygenator. We have a artificial extracorporeal lung to rest native lungs, and I will reiterate what was said before, in VV ECMO, we are not directly supporting cardiac function, but it is quite common to see patients who have improved hemodynamics, improved blood pressure, decreased pressure requirement on VV ECMO, largely because of the reduction in intrathoracic pressure when you don't need to be using the ventilator as aggressively. But I also believe that there is a direct benefit on cardiac function by increasing oxygen delivery to the entire body, including the myocardium. So it's very common to immediately see improvement in hemodynamics once you put a patient on VV ECMO support, but not as dramatically or titratably as you would see on veno arterial support. Again, all these talks always have some schematic like this showing the patient and the cannulas, and really trying to show you that the basic circuitry is quite simple. You're removing venous blood, putting it through a pump, putting that pumped blood through an oxygenator, taking in oxygen, removing carbon dioxide, and then putting that oxygenated blood back into the patient. At the most simple level, that's what we're doing. This is an example of VV ECMO with a femoral drainage cannula and an jugular return cannula. This is from a nice review article from 2011 in the New England Journal. Different from VA ECMO, which I'm not going to talk about in more detail, where we're putting the blood back into the femoral artery rather than into the venous system. If you put blood into the femoral artery, you're bypassing the heart and lungs and providing direct blood pressure support into the arterial system. Here's the same slide that Steve showed, which I like as well, so I had to put it in my talk as well. We didn't compare slides beforehand, but really hammering down on that point that ECMO is partial bypass. You take, of all the venous blood that's pooling in the right atrium, a percentage of that blood goes through the ECMO circuit, and assuming your ECMO circuit is working normally, which it should be, very quickly goes to 100% saturation. So it goes from dark blue blood to bright red blood very quickly in passing through the oxygenator and becomes red blood. That red blood comes back into the heart, still needs to go through the pulmonary circulation, but it goes through the pulmonary circulation alongside that native venous blood that is not drained, because the cannulas never drain all of the venous blood. So you have venous blood with venous oxygenation, which is blue, going through the pulmonary circulation and mixing with very well oxygenated ECMO red blood in the right atrium in this example, and then pooling into a mixed purple blood of those two circulations. And what you measure in your peripheral saturation in the arterial system is going to be a weighted average of those two blood streams. Your native venous flow, which is either completely venous oxygenation. It may pick up some oxygen in the lungs, depending on what your lungs are able to do or not. It may pick up zero oxygen in the lungs if the lungs are so dysfunctional and on such low ventilator pressures that they are contributing no gas exchange. And then it's going to mix with the well-oxygenated blood, and the weighted average will determine your arterial saturation. So here's, in words, what I just said. You're dividing the net cardiac output into two blood flows, one fully oxygenated, one poorly oxygenated, and mixing those so that they can go out to the patient's body. Weighted average is the key concept here. You'll have 100% saturated blood, venous saturated blood. It's not going to be 1-to-1. It's going to be some ratio depending on what your ECMO flow is and what your total cardiac output was. You can think of this mathematically, if you're more mathematically inclined, as you have two flows, that an ECMO flow and a non-ECMO flow that sum to your total flow or your cardiac output. Both of those contribute to oxygen delivery. The ECMO flow is more effective with oxygen delivery because it's 100% saturated. The non-ECMO flow is less effective because it's venous saturated at a minimum and maybe more saturated if the lungs contribute. And to get your peripheral arterial saturation, it's going to be the weighted average based on how much of the flow relative to the cardiac output is going through each of those circulations. And you can take that, you can derive that equation on the third line, and you can rearrange that to get a relationship between cardiac output, ECMO flow, and your venous saturations. So, as has been said before, and I will reiterate it is not normal to see 100% saturation on VV ECMO because normally the lungs are not contributing effectively because they are failing. And we normally see something less than 100% because we have the 100% from the ECMO flow and the 60% or something along those lines from the non-ECMO flow, and those are meeting to give us our peripheral arterial saturation. If your saturation is in the 80s, but your lactate is normal, as Steve said, if your venous saturation is stable and you don't have markers of end organ dysfunction related to inadequate cardiac output, you are stable on ECMO. You do not want to try to achieve a saturation of 99 or 100% because it's difficult and would require using the lungs more aggressively than you might want to. And the main things you want to look at are adequate oxygen delivery at the level of tissue perfusion. The crude markers that we have most commonly are lactate levels and venous oxygenation levels. As I said, oxygen delivery comes from both of these contributions, ECMO and non-ECMO, some of the same equations that Steve showed. The total delivery is the sum of these two blood streams. The total saturation is the weighted average of these two blood streams. There's that same graph one more time, and just hammering down the point that saturation is going to relate to these ratio of these two blood flows. Oxygen delivery is going to be the combination of these two blood flows. Okay, so that's the physiologic basis of why we think ECMO is indicated in certain situations of severe ARDS, severe hypoxemia, injurious ventilator settings. If you want to get some reference for how we decide who will benefit, the best people to go to are ELSO, because this is the international organization founded by Robert Bartlett that keeps track of all ECMO patients around the world and strategies and outcomes and technology. This guideline was published in 2021. Here is the list of indications and contraindications for ECMO. You see number at the top there, you have 1, 2, 3, hypoxemic respiratory failure, P to F less than 80 after optimal medical management, including a trial of prone positioning. So they give a strong endorsement to prone positioning. That's the best evidence-based treatment of what we reviewed yesterday for ARDS. And they give a vague optimal medical management to show you that you shouldn't just immediately put somebody on ECMO because they have ARDS, because there are lots of things, prone positioning, recruitment maneuvers, paralysis, PEEP titration, that may be able to stabilize a patient and avoid the invasiveness of ECMO. Number 2, hypercapnic respiratory failure, despite optimal conventional ventilation, and specifically looking at keeping your plateau pressure less than 30, ideally, keeping your rate ideally less or much less than 35 breaths per minute. And then number 3 is the bridge to lung transplantation or primary graft dysfunction after a lung transplant. Specific clinical conditions that often meet these criteria. Number 1, the top of the list, ARDS. But we also have situations, eosinophilic pneumonia, pulmonary hemorrhage, severe asthma, trauma, bronchopleural fistula that can meet these criteria as well. Contraindications at the bottom of this chart are not as concrete as you might want them to be, but we want to find the patient who has very high acuity severe respiratory failure, but simultaneously a reasonable expectation of recovery, something that we believe to be reversible, and a patient that we believe to have the systemic physiologic reserve to recover. And often, you don't need necessarily ongoing anticoagulation with VV ECMO, but you often need at least some anticoagulation to go on VV ECMO, and you may very well need anticoagulation going forward. VA ECMO, which I'm not going to talk about, you absolutely need anticoagulation. If you have a patient who has a 100% contraindication to anticoagulation, that is a consideration. So CNS hemorrhage, central nervous system hemorrhage, is top of the list. Significant central nervous system injury is number 2, largely because of the concern that you may not have a recoverable patient in terms of neurologic function, even if you can get the lungs better. Systemic bleeding, contraindications to anticoagulation. Immunosuppression is relative contraindication. I can't tell you exactly a quantitative measure of immune status, but somebody who is not going to tolerate the infectious risk of prolonged extracorporeal circulation is at higher risk. Older age, there's no threshold which has been clearly defined. The joke we always had in Michigan was that older age always was younger than Robert Bartlett as he progressed through his time and unfortunately passed a month ago or so. We've had patients, ideally we like to find the patients who are in their 20s or in their 30s who are previously healthy, who have some acute illness and may recover, but we've had patients in their 50s, in their 60s, probably even in their 70s in our practice. As they get older, it depends not just on their age, but what is their physiologic status, what is their quality of life, what are their comorbidities.
You're not telling them our standard joke?
I already did, yeah, you walked out. And also controversial is patients do well who are put on ECMO relatively early in the course of the respiratory failure, not hour 0 or hour 2, but we don't want to see the patient who's been on the ventilator for more than a week, more than 2 weeks, on high vent settings, already suffering complications of ventilator-induced lung injury, already having significant deconditioning. We want to identify the patient ideally who's been on for a week or less. Not set in stone, but this is what we look for. There are risk scores. This is something called the RESP score, which was made by looking at past ECMO patients from the ELSO registry and seeing what they get points for and not. You can get a version of this on your iPhone or your smartphone. You can see there are positive and negative score elements. The -7 there is for CNS dysfunction. -3 is for age greater than 60. +11 is for asthma. If you have the patient with severe asthma, that's actually a very good prognosis. They may not need ECMO at all, but if they do need ECMO, they're likely to have a short run and come off of it. So you can add up all the pluses and minuses in this category and come up with a score. And based on your total score, there is a risk class and a survival prediction. So this is something you can use as a quantitative predictor, not perfect, but a evidence-based starting place. Guidelines for ARDS in general evolve over time. This is the most recent ATS, American Thoracic Society, ARDS guideline from 2024, just last year. These are the main, not all the recommendations, but the main new recommendations. The strong recommendation at the top was against prolonged recruitment based on the ART trial that I talked about yesterday, as well as against high-frequency oscillatory ventilation, which we mentioned yesterday. The new recommendations in favor, conditional, the yellow, are for neuromuscular blockers. VV ECMO has now made it into the conditional recommendations, as well as steroids and higher PEEP. The bump up in steroids is really because of COVID-19. We all of a sudden had many cases of ARDS, which happened to be steroid responsive in general because of the nature of viral pneumonia. I think it's a little bit strange to recommend steroids for all ARDS patients based on the COVID evidence, but that's where we are. And then the strong recommendations in favor, proning and lung protective ventilation with the tidal volume and plateau pressure limitation. But until 2024, ECMO was not on this list at all. So things have evolved, data has evolved. It's now made it to the not the green, but it's out of the red into the yellow, and we'll talk more about that. The biggest trial that I'll go into in more detail, published in 2018 in New England Journal, is called EOLIA. It was a randomized controlled trial of VV ECMO versus not VV ECMO for ARDS. You can imagine it's challenging to design and do that trial. It's a surgical therapy for a life-threatening condition, and finding the equipoise and the practitioners who are willing to randomize their patients to what they believe may be a life-saving maneuver with VV ECMO versus what may be futile with conventional ventilation is difficult, but it really had to be done to get a database that we could move forward with. The main reason I put it here is because they had very specific eligibility criteria, which, because this is the largest RCT, largely have become the eligibility criteria in guidelines. That P to F ratio less than 50 for greater than 3 hours or less than 80 for greater than 6 hours is what was in the ELSO guidelines as well. And it shows you that they do want to give you not days or weeks, but hours to work on the patient and see if the gas exchange abnormalities are treatable or improvable with less invasive technologies. And then you also have the considerations of hypercarbia, respiratory acidemia, and issues of tidal volume reduction and plateau pressure reduction. So this is a good starting point, but it doesn't mean that nobody follows this completely to the letter. We don't have patients with a stopwatch when they arrive in the ICU and say, have we reached 6 hours? Is their P to F still less than 80? But that's what we're thinking about. The clock is ticking when you're making these decisions.
And it also says after optimization.
Right. And optimization is left to the judgment of the team taking care of them. Here is a specific ELSO document related to COVID-19 that basically is summarizing their EOLIA criteria. They show if you have hypoxemia, P to F less than 150, higher up are the medical management, the prone positioning, the blockade, the high PEEP strategy, recruitment maneuvers to consider. And if those are not working and you get to those criteria on the bottom left and there's no contraindication to ECMO, recommend ECMO. And then on the right side is the does not meet the oxygenation criteria, but may meet the ventilation criteria. That can be a consideration as well. I've been working in the ICU for 20 years now. I probably have, less than a fingers on my hand patients who were put on VV ECMO for hypercarbia, and dozens, hundreds who've been put on for hypoxemia. That's much, much more common in clinical practice. All right. So that's sort of what we're thinking about in terms of indications. In terms of you've made the decision to put your patient on ECMO, how are you going to do it? What are the different physical, technical strategies you can use? That's not a simple question, and there are multiple strategies. The most common ones are shown on this slide, where you have on the left 2 cannulas in a femoral vein, one on each side. You have in the middle 1 cannula in a femoral vein and 1 cannula in a jugular vein. And then you have on the far right a single cannula which has 2 lumens that goes in through the internal jugular vein and goes down to the IVC and allows you to drain blood from the IVC and from the SVC and then reinfuse it directly into the right atrium. That's the newer configuration, but it's been around for quite some time now. I'm going to go into these in some more detail. 2-site cannulation, either femoral-femoral or femoral-jugular, is common because it's historically the easiest and the quickest to do. Has been done at the bedside in the ICU, at the bedside in the emergency department, in the operating room, without needing to move the patient to a different location. You can get the highest flows with the large cannulas you can put in at the bedside. You're not limited by the specific dimensions of a specialized cannula. The positioning to get them into place can be more straightforward. It doesn't necessarily mean that you don't have to micromanage them once they're in place, but to get them into place and to get the patient on ECMO is a little bit more straightforward and faster. Drawbacks are obviously more big holes and big vessels. 2 is more than 1. Certainly mobility, when you're any kind of femoral cannulation, either with a single femoral or both femorals, limits your ability to ambulate a patient. Have there been patients who have been mobilized and ambulated with femoral cannulas? Yes, but it's not as easy as it would be with neck cannulas. And recirculation, I'm going to mention a little bit more detail, and it sounds like Steve's going to talk more about later today as well. What is recirculation? It's a unique problem of VV ECMO where the blood that comes back to the patient after being oxygenated instead of going through the pulmonary circulation and out to the body, goes right back into the drainage cannula and goes through the oxygenator again. And that's an inefficient system to reoxygenate blood, which has already been oxygenated and has not been delivered to the body. And depending on what cannulation strategy you use, this may be more or less of a clinically relevant problem. So here's an example with femoral-jugular cannulation. You can see on the left where the cannulas enter. You can see on the right, one is in the SVC above the right atrium, one is in the IVC below the right atrium, and the blood coming back from the SVC cannula, you want that big yellow arrow to be going through the tricuspid valve into the right ventricle, and you want the small yellow arrow going directly back down into the venous cannula to be much smaller than the big yellow arrow. So you want those cannulas to be you want them to be in large veins so they can maintain high flows, but not so close together that recirculation flow is problematic. So the cannula position is relevant. Also, how fast you're pumping the ECMO circuit is relevant. If you're creating a lot of negative pressure and high RPMs, high flows, that's going to promote more blood flow into the drainage cannula. If you have a lower flow, that's going to promote more native blood flow into the right ventricle. So those are some of the considerations there. And so the problem is when that yellow arrow becomes big and you're mostly going straight back into your cannula and not into the patient. How would you diagnose this at the bedside? So just think about it clinically. Your oxygenated blood is staying in a circuit in the machine and not going to the patient. You're going to see peripheral hypoxemia, but if you took a sample of the blood going into the ECMO machine in the venous cannula before the oxygenator, it's going to be highly oxygenated. So some of our newer devices, you continuously measure the pre-oxygenator SvO2 and it's displayed. Some of them you have to draw a blood sample and send it to the lab, but in either case, seeing a very high venous saturation at the same time as a unacceptably low arterial saturation is a concern for recirculation. You can also get a sense, when you look at ECMO cannulas on a patient or on their bedside, you should be able very easily to see dark blood in the venous cannula, bright red blood in the arterial cannula. If those look identical to the eye, showing that arterial saturation is low and that venous saturation is up, that can be a early concern that there is recirculation, which you can then investigate more fully. What can be done to address this? I mentioned already adjusting cannula positions. Yes, Raghu?
There are formula investigations.
Yeah.
We accept up to 15% of recirculation, but the recirculation goes beyond 15 and patient is consistently hypoxic, then we may have to change the cannula position.
Correct. So general maneuvers, I mentioned adjusting the positions. I mentioned decreasing the ECMO flow. You can also try to promote native flow by using inotropes to help the cardiac output, and you may have to consider a different cannulation strategy from what you have. The obvious downside of decreasing the ECMO pump speed and flow is that you're decreasing the oxygen delivery from the ECMO circuit, so it has to be a balance of it may help with recirculation, but it may limit your global oxygen delivery as well. So here's the femoral-jugular approach. One femoral vein, one IJ vein. It tends to be the right IJ because that's a straight shot down to the right atrium, not having to go across the midline with the brachiocephalic vein. Typically, the drainage cannula is femoral and the return cannula is jugular. It doesn't have to be that way. There have been situations where the jugular has been the drainage and the femoral has been the return, but the most common situation is the opposite. There is clearly potential for recirculation. The examples that I showed you were with femoral jugular cannulation strategies. That being said, this is still the most common initial strategy for adult respiratory support. Basically, if you are able to put in a central line, you are able to put in an ECMO cannula. It's a bigger central line with more steps of dilation, but it's not different in terms of the skill set needed. Ultrasound is used at the bedside like it would be for most central lines, Seldinger technique, serial dilation, etc. In terms of the positioning, as was mentioned by Steve, you want that return cannula basically in or very close to the right atrium at the SVC right atrial junction, and you want that drainage cannula to be in the IVC at just below the hepatic veins. Often you're looking at a X-ray or possibly fluoroscopy if you happen to be in a place that has it, and you're looking for around the T12 to L1 vertebrae as the approximate location.
And for the return cannula, the vertebral level is T6?
It's going to be, we don't look at the level of the spine as much because you can usually see the heart and the right atrial. It's at the level of the SVC right atrial junction. And you want to, if at all possible, maintain a distance of 10 centimeters between them to empirically make the chance of recirculation less rather than more. The femoral, yes?
So if we use opposite side left internal jugular, would it reduce recirculation?
It depends on where the catheter ends. So in principle, if your catheter is shorter, it may decrease recirculation, but it also may be difficult to have the adequate flows. You want to get into the largest veins possible so you have the adequate drainage and adequate flow. So I wouldn't recommend putting in too short of a cannula or a left-sided cannula just for the recirculation problem, because then you may run into issues with overall ECMO support, but fair question. The fem-fem approach is also two-site, doesn't use the neck at all. And the main reason to do this is if you have a patient where, for some clinical anatomical reason, it's not safe to cannulate the neck. That could be you tried to cannulate the neck and were not successful. That could be the patient has a cervical spine injury and is in a mandatory C-collar. That could be the patient has stenosis or thrombosis of the IJ vessels. That could be it's a dialysis patient who already has long-term upper extremity access. It's relatively more common in trauma patients because they have a higher likelihood of having a C-spine injury, or at least a concern for C-spine injury, as well as renal failure patients. It's also often, sometimes you have a patient who you start with that femoral-jugular approach, and then you make a decision to go to a single-stage cannula for ongoing ECMO support, but you need to take out that existing cannula to put the new one in. During that time of not being on support, you need to have a bridge. So it can be in the operating room or in the radiology suite, a temporary strategy to go from femoral-jugular to femoral-femoral, and then to single-stage jugular, excuse me. Here you can see there are now two cannulas, one long and one short, going into the IVC, and you basically want to have the return cannula placed close to the IVC right atrial junction and the drainage cannula placed lower. You can imagine if you have those cannulas too close to each other, the recirculation can be more of a problem. If you have, just by not thinking of it correctly, putting in the return through the shorter cannula, it's more likely to then get sucked back through the longer cannula. So you want the longer cannula to be the return, the shorter cannula to be the drainage, but you don't want it to be too short because then you may be in an iliac vessel rather than the IVC and not get the flows that you need to support the patient. I'm not a cannulator, so I don't have all the answers to cannulation questions, but Raghu and Steve probably have more to say about that in the sessions as well. Certainly potential for recirculation depending on where those two cannulas are relative to each other. All right, so the single site dual-lumen approach, typically done from the right IJ. I'll show some more pictures of the cannulas. They have holes both in the SVC and the IVC that drain the blood, and then they have a separate hole in the right atrium that returns the blood directed at the tricuspid valve. So it's a more difficult placement because you need to know that that cannula is going in through the neck, through the right atrium, into the IVC. You don't want it to go into the tricuspid valve or into the right ventricle. If it does do that, you can have major problems with cardiac injury, arrhythmia, tamponade, perforation, not trivial or subtle complications. This has been tried at the bedside with serial x-rays. I've been involved in those processes. It's really uncomfortable. Having real-time imaging with fluoroscopy is considered mandatory in our institution. The other alternative, depending on what your resources are, is real-time echocardiography by somebody who's really good at interpreting cannula position going through the right atrium into the IVC. At Michigan, most of the time we do this either in the operating room or in the radiology suite with fluoroscopy, and it's not permissible at the bedside without exceptions that I'm aware of. Yes?
I just got one question. Why can't we place the same like dual-lumen cannula through the femoral approach?
You, in theory, could. It would have to be a very long cannula, and I don't know if those are commercially made. So,
Then the whole idea behind this, Raj is going to tell you, is what is the big advantage of the neck?
Mobilization.
So the biggest advantage is mobilization.
yeah.
So there are a group of people where we are thinking of lung transplant or whatever. They are on ECMO support, and we take off the ventilator support. So they are mobilizing and they are walking around. If you have decided as a bridge to lung transplantation, that's the biggest advantage of the neck cannula. They are mobile, they are walking, and then we say, okay, now they are literally ready for a lung transplant.
Yeah. If you were restricted to femoral because of whatever consideration, having femoral-femoral cannulation is probably more straightforward than trying to do a femoral single site. And most importantly, the cannulas don't exist. So unless if you want to invent one and become the yes, Steve.
I've never seen anybody use a dual lumen for femoral. Like they said, the length is going to be problematic. Something that people are starting to do, although I don't know if that's a great idea or not, is using subclavian for these dual lumens. The reason I don't necessarily love it, especially with the cannula that Ross is describing, is that these are really rigid and they're designed to be so you can breathe bicavally. To put a curve in there, I know the cannule's not really designed for that. So, but you could theoretically do it, and people have been doing it.
And this is the same thing that Kapil was asking about brachiocephalic. So if I am cannulating the left side, my sphincters are extra tight.
Yeah. And you can just
All you need to do is that guide wire, you're following the guide wire, but we do it bedside.
yeah.
And you're gradually advancing the catheter, or if it goes straight into the brachiocephalic, we are toast. And the patient is toast too.
Yes. Toast all around. And then here you can see a nice picture on the right here. Here's that. This is what the cross section of the single site looks like. You have a larger venous lumen and then a smaller return lumen that is directed at the tricuspid valve in the right atrium. It has to be rotated correctly because that return lumen is on one side of the cannula and it has markers that you can see on fluoroscopy, but you want that blood to be going towards the valve, not towards the wall of the right atrium. And here's another, I went online and found multiple pictures just to really hammer home what we're looking at here. You want that blood flow to be going towards the tricuspid valve into the right ventricle. Here's one where they show it in red, sort of going across the valve into the right ventricle, and you see the blue blood draining from below and above the outlet lumen there. There's at least 2 manufacturers in North America of these cannulas. I don't know if there are more that you're aware of, Steve. And correct. And I'm purposely not using trade names in general, but just showing you that this is not a single product. There are at least some competition in the market. All right, so here's another picture showing the same thing. So in summary, for these VV cannulation options, femoral-jugular, the most common, gives you high flows, is done at the bedside, allows some mobility. Femoral-femoral, really only when you don't have access to the neck or aren't able to cannulate the neck. And then single site for those longer-term patients who you're trying to get mobilized towards lung transplant, if it's more of a less emergent, more elective placement, if you want to favor mobility of the patient, if you want to have an awake patient, the flows may be somewhat lower than you would get through 2-cannula cannulation. And that becomes challenging. So ARDS is never an elective diagnosis or an elective procedure, but you can have somebody who is relatively stable ARDS, who you can transport safely to the operating room or the radiology suite, and you can have the patient who is suffering from cardiac arrest or near cardiac arrest or severe hypoxemia where you don't have that option safely at all. So that elective is in quotation marks. Yes?
Why is it resolving ARDS?
So that's the situation there where you have a long-term ARDS patient where you may have stabilized them initially with femoral-jugular, and now they're getting better, but it's resolving slowly, and you want to have them more participating in physical therapy, more mobility, potentially extubated and awake, potentially trached and awake, so it may be a longer-term support rather than that initial stabilization.
There are other conditions like pulmonary alveolar proteinosis, or we have a whole bunch of international pulmonologists. They do some really, really tricky procedures with the bronchial stent, and the patients are incredibly hypoxic. So there are times we will cannulate them electively so that they can do their procedure.
Yeah, so it can be that's a different indication, sort of a procedural support for some kind of airway operation or airway procedure where you cannot rely on conventional ventilation to get the patient through it. The newest thing on the market in terms of VV, and what to call this is a little bit confusing because I put it as VV, but your catheter is ending up in a artery, not a vein, but it's a pulmonary artery, not a systemic artery. And the pulmonary artery, as we discussed, is deoxygenated blood, not oxygenated blood. But there is a couple of products on the market that are VPA cannulas, where they go in through a vein, they go into the right atrium, they go across the tricuspid valve, they go through the pulmonic valve into the pulmonary artery. They do the same thing that a PA catheter does, but they're much bigger than a PA catheter, and it's an ECMO cannula. In order to place this, you absolutely need fluoroscopy because and the way that it's done is that you do a right heart catheterization, put in a PA catheter into the pulmonary artery, then put a really long wire through that PA catheter, remove the catheter over the wire, and then put in this much larger ECMO cannula over the wire into the pulmonary artery. So it's a different type of support. Why would we go through all that trouble to put the return cannula into the PA rather than leaving it in the right atrium? Any thoughts? Say that again? So recirculation, it is much, much lower recirculation if you do this successfully, because now your return blood is coming out here in the pulmonary artery. The chance of it getting back into the drainage here is the smallest of any of these configurations. But that's not the main reason that we use it, although it is a valid consideration.
We talked about
most deoxygenated blood goes into the pulmonary artery.
Yeah, so this essentially is a form of right ventricular assist device because it's not bypassing the heart, but it is bypassing the right ventricle. And so you are pumping blood under pressure into the pulmonary artery. You are supporting the right heart and increasing the pulmonary blood flow directly, whereas all those other strategies that I talked about before, you're taking blood out of the venous system and putting it back into the venous system before you get to the heart. Therefore, you're not providing any net change in flow in the heart itself. So this is really a hybrid between a ECMO device and a cardiac device, but a right-sided cardiac device, not a left-sided cardiac device. And it's not brand new, but it's newer than the other techniques, and it has had increased interest in the COVID and post-COVID world that we live in. Here's another picture showing you that cannula coming down into the right atrium, and then it has to really do a 180-degree turn. So imagine trying to do that without fluoro. Your sphincter tone would be the highest. Why would we consider that? Because right heart failure, acute cor pulmonale, is a real phenomenon with ARDS. It's a real phenomenon with COVID ARDS as well as other forms of ARDS. This is a paper from 2016 showing 750 patients who all had formal TEEs at the time of their diagnosis. 22% of them had echocardiographic diagnosable right heart failure. And the risk factors for that include hypercarbia, high driving pressures, hypoxemia, low P to F ratio, all things obviously that you see in ARDS. So there is this patient phenomenon of having respiratory failure, which begets right heart dysfunction and right heart failure. And do you want to wait for the patient to develop right heart failure before considering some kind of right-sided support, or do you want to potentially prevent that right heart failure by providing right heart support from the beginning? That's not an answered question yet, but it is being thought about. So I'm going to take a break now, have some questions, and I'm going to go into some of the clinical studies in the next session right now. So any questions about the cannulation strategies that I showed so far? You look like you're about to, yes.
Okay, about the VPA, so you said the indication is acute right heart failure. So in majority of the conditions where we have right heart failure, we have associated severe pulmonary arterial hypertension.
Mm-hmm.
So will it be like really useful?
Pulmonary hypertension, the pressures in the pulmonary circulation are not the major problem. It's whether those pressures lead to the right ventricle failing. So if you can bypass the right ventricle and pump blood into the pulmonary circulation, you should be able to create the flows to overcome the elevated pressures. What's that? You're offloading the right ventricle, correct. So this is relatively new technology. This is not standard of care for right heart dysfunction, but this is a consideration for right heart dysfunction. And then we have this population of right heart dysfunction associated with respiratory failure, which became more evident when we had a lot of respiratory failure with COVID in 2020 and 2021.
Just a simple thing, instead of going for pulmonary artery cannulation, why can't we just give nitrate right into the right ventricle?
So you could put a catheter directly into the right ventricle. I've never seen that design, and my suspicion, the reason that's not designed is that my experience with PA catheters is that the right ventricle is a much more arrhythmogenic place to have a foreign body than the pulmonary artery. During the placement of a PA catheter, you often see transient ectopy, transient ventricular arrhythmias, irritability of the right heart, which tends to resolve once that tip of the catheter makes it into the pulmonary artery. So putting a really large cannula into the RV with really high flows going through it, I think would cause a lot of irritability of the right ventricle. And probably for that reason, there's been no commercial product designed to terminate in the right ventricle.
Highly arrhythmogenic.
Yeah.
For the cannulas, what is the theoretical and practical limit to how long we can keep them inside once we put it in?
Yeah, so when I have colleagues who give these talks, they say from the beginning that the FDA indication for these cannulas is 6 hours or less of support. And yeah, and we clinically have patients who have had months of support. So
Almost a year.
yeah. So, and basically these have been approved for use in the United States for cardiopulmonary bypass type situations, yet clinically we and many other institutions use them for prolonged support for cardiorespiratory failure. I don't think there's any inherent limit, but I should say out loud that everything that I'm discussing here exceeds the FDA labeling of these cannulas in the US.
I mean, for those patients who are there for months,
Yeah.
do we need to change the cannula? We can continue.
No, you never need to change the cannulas unless there is a specific cannula problem or specific benefit from a different cannulation strategy. So there's
Also, Deepak, how will you change it?
We go to the opposite side, we go to the neck, from the neck we go to the
Yeah,
front.
you can put a new site.
Yes.
Yeah, but it is really hard, once you have dilated that vein that much, you can't keep it small. So you put a guide wire through it, it will bleed like nobody's business.
Yeah.
So you can't, there is no need, and it's fairly,
Yeah, well, we commonly have a situation where there's somebody who has ECMO cannulas in and develops bacteremia, and then the infectious disease doctors come by and say, "Oh, just please, remove and replace all the central lines." And we tell them, "No, we will not do that. We know this is bad, but we're still not going to exchange lines because of an infection in somebody who is every second dependent on this support."
And Deepak, what happens is, once you have the ECMO cannulas for more than 2-3 weeks, you invariably will get some degree of coagulopathy. In those patients, we even think twice before we do a peripheral blood transfusion. That hole will bleed for hours. A venous puncture. So it gives you an idea of what we are eating.
So what you do if you remove the cannula, what you do with that hole in the vein?
What?
He's saying, what do you do to allow the hole in the vein to heal when you remove the cannula?
Or okay, let's say you're putting you have dilated it, you have put the guide wire, keep dilating, you are up to say 25, and suddenly your guide wire comes out, you have lost the track. What are you going to do?
Cut down. Down to the next step.
Not necessary at all. You just close the skin.
So when
Put
we,
some pressure, it's venous pressure, close the skin. So they heal. Yeah, a big part of them will develop DVTs. So Lena is very particular when she is using them, she will put something like an IVC filter.
Mm-hmm.
But most of them, if they get clearly contraindicated to anticoagulation, then we will consider an
Yeah.
IVC.
And when these cannulas are removed because the patient has improved, you basically have purse strings around the cannula, pull it very tight, hold pressure for a long time, and
But that's at the skin level.
yeah,
So
yeah.
we never address the hole in
But
the
it's very rare that you have
Because
a.
it is percutaneous, it's not an issue at all.
That being said, because I am not trained as a surgeon, that's one of the reasons why I have not chosen to pursue becoming a cannulator, because some of the problems you can create as a ECMO cannulator require a surgeon to fix. And I prefer having the surgeon involved from the beginning than, calling Raghu saying, I'm in trouble here. There's a big hole in the vein that I won't stop. Can you come and help me? And so
so when you remove the cannula, you continue anticoagulation for how long?
depends on the situation. I mean, there are patients who we manage with VV ECMO with no anticoagulation, so it's not necessarily continued. If they have a indication for ECMO or for some other reason, you typically would hold it for the decannulation and resume it maybe 6 hours later, maybe longer, depending on if they're bleeding, if their hemoglobin is stable, what their coagulation counts are. There's not a similar.
Underlying condition too, because
Yeah.
H5N1, COVID, we kept them for 6 months.
Right, but in terms of removing it, when to restart it after remove, I think it's going to depend on the specifics.
I have a question regarding so patients with ARDS who already have central line catheters. Often we don't think about ECMO when we're
Yeah.
So they may have a right IJV catheter,
Mhm.
and there is a certain subset who do develop thrombosis of around that line,
Mhm.
especially when they've had multiple cannulations. So if the patient has had proven DVT, could you still cannulate through that if you do not have any other subset? Do an embolectomy and do it?
No, we don't do embolectomy. And proven DVT, if somebody is clotted up, it can get really hard. Proven DVT we won't. So if we have the femoral, we will, then we will say, okay, let's do the IJ.
Okay.
We have done this experiment. There are times, I used to do a VA ECMO cannula prior to organ harvest. And I still remember one patient, we kept trying and did go to the, later on we found out the patient had an IVC filter. So I tried to get the IVC filter. So we won't go.
Yeah, and what a common situation is that you have a patient in the ICU with a right IJ triple lumen catheter. We commonly will change that over a wire to an ECMO cannula. In general, we don't like changing lines over wires if you can avoid it for infectious reasons, but if you have a indwelling line, the benefit of using that for cannulation, if there is not a big thrombosis, is higher than the risk of removing it and doing another stick.
Yeah, and at the same time, so that we will prepare the left IJ for a central line.
Yeah.
Because now this patient is on multiple pressure, antibiotic, they need IV lines. So we cannot give all this stuff to ECMO. So once we use, so before I am prepping to dilate that, put an IJ, I will put a left IJ for a central.
Cabo?
So how frequently these cannulas get blocked or get blocked because of no flows or fluosis?
Very, very rare. I mean, usually if there are problems with thrombosis, it's more commonly in the oxygenator.
Even if you are not using any anticoagulation.
Yeah, it's a much more common a problem in the oxygenator than in the cannulas themselves.
And we use couple when we are faced with the situation that you try anticoagulation, patient bleeds, we stop the anticoagulation, then we try again bleed, we say, okay, we're not going to use. So what we will do is we will keep the flow high. And we will cut off the sweep as a trial run rather than fiddle around with the flow. So we keep the flow on the higher side, but we cut off the sweep, and that's another way to test for.
Yeah, but having continuous high flow through the cannulas is a pretty good method of keeping them patent. So, have you encountered thrombosis within the cannulas with any frequency?
Almost never.
Yeah. Okay.
If the patient is mostly will be having some multi-organ failure, so if patient is on ECMO and also some dialysis is going on, so in those cases, please share your experience.
Yeah, so dialysis is a good question, and it's challenging with the access. So it is possible to run CRRT through the ECMO circuit, which is when that is technically feasible, is what we prefer, so we don't have to have separate dialysis access. There are sometimes challenges with maintaining the pressure gradients and the flow through the dialysis circuit, but typically it's typically done with these pigtails that are just on either side of the oxygenator. The other alternative is having a separate dedicated hemodialysis catheter and running CRRT as one extracorporeal circuit and running ECMO as the other extracorporeal circuit. And sometimes that's necessary, but when we can get it through the ECMO circuit, that's preferable and is possible.
So we can connect that like there will be add-ons to the ECMO circuit. Right?
Correct.
Yeah, that's going to be, we're going to cover it in the.
Okay. But no, very good question. Yes.
You had mentioned regarding use of the same for hypercarbia. You said less than a handful of patients who have been done. How do you compare the indication? Because we have other extracorporeal mechanisms for CO2 removal. So is the indication when there is a refractory indication to the extracorporeal removal, or is it because it is associated with the hypoxia as well?
Yeah. The extracorporeal CO2 removal is a technology which has been studied, but is not routinely used in North America, and I don't know if it is in other places.
Italian study.
Italians use a lot. Yeah, Italians use a lot. Or they use a lot.
Yeah, so that's basically CO2 dialysis, where you have a much smaller catheter, much lower flows. It's not ECMO. So in North America, that's not readily available to us, and so there have been, as I said, a small number in my career of patients with refractory hypercarbia related to severe asthma or something else who cannot be controlled by other means, and you would consider VV ECMO as a treatment for that because we don't have something in between like extracorporeal CO2 removal outside of a clinical trial. But good question. All right. So lots of great questions. I'm going to jump into the latter part of my talk now, which is about some of the clinical studies. You can see that this is the first randomized controlled trial of ECMO back in 1979. The first author was Warren Zapol, who was an anesthesiologist, my former chairperson at Massachusetts General where I did my training. You can see the fifth author is Robert Bartlett. So he was involved in this trial design and write-up as well. And this is mostly here for historical interest. This is not the way that we practice currently. This was 1979. They didn't even call it ARDS. They called it severe acute respiratory failure. As you'll see, they use VA ECMO for everybody, which is not the standard currently. And this was well before lung protective ventilation was the standard of care for respiratory failure, so there was really no attempt to do low tidal volume or lung protective ventilation. And I say all these things before I show you the results. There were 90 patients, VA ECMO versus mechanical ventilation alone. There were transfusion requirements of over 2 liters a day in the ECMO group, so their abilities of maintaining hemostasis and managing coagulopathy were limited, and there was absolutely no protocol for lung protective ventilation on or off ECMO at the time. There's the survival curves on the left, and you can see 2 lines which kind of crisscross each other, but what's most impressive is they both go down very steadily. And of these 90 total patients, you see there were survived after respiratory improvement were 4 on the ECMO side and 4 on the mechanical ventilation side. So well over 3/4 of the patients died during the trial equally in both groups. So this was a severely sick group of patients who were not receiving the care for ARDS that we would called the standard these days. And basically the comment by the authors was that relentless destruction of the lung was common to patients treated with both therapies. Yeah, so, but and that put a big damper in the popularity of ECMO around the country and around the world, because this trial done, funded by the NIH in the U.S., done in Boston, Bartlett involved, really did not show a clear clinical benefit. Fortunately for ECMO, and I'm not going to go into it in detail, around the same time in the mid-70s, there were positive trials in neonatal respiratory failure, which basically allowed the technology to continue to become available and to continue to be studied in primarily pediatric populations, but selectively in adult populations as well. So the next major trial is all the way in 2009, right in time for H1N1, and this was called the CESAR trial, not named after the Roman emperor, but spelled differently. And it's a very interesting trial. This was done in the UK, in England. Giles Peake is the first author. Giles Peake is a cardiothoracic surgeon who ran a ICU in a specific, I can't remember the name of the city, but it's a specific hospital. You remember what? Leeds? It's not in London, it's not in Manchester, it's a smaller English city, but he had a specific cardiothoracic unit and a specific interest in ECMO and extracorporeal support, and basically designed a trial where the randomization was, you have bad respiratory failure in the UK, you get randomized to staying where you are or being transferred to Giles Peake's ICU. And he and his team would take care of the patient if they were transferred, and if they were not transferred, then whoever was taking care of them wherever they were would continue taking care of them. So the control group is kind of this black box where you don't know exactly what's happening, you don't have the ability to control the therapies. And the experimental group, the main intervention is not ECMO per se, it's being transferred to a specialty center which is interested in ECMO, but does not include necessarily going on ECMO. So the way it was described was a controlled trial of conventional management versus referral to a specialty center that offers ECMO. And as you would expect from that description, of the 90 patients who were referred, 68 of them went on ECMO. So more than half, but certainly not 90% or 100%. So you're in the area of around 70-something% of the patients went on ECMO, and really no control of the treatments received outside of that. So I hesitate, and I think he had difficulty getting this published in a major journal because it didn't have all of the hallmarks of an RCT. But that group of patients who was transferred to his unit had better survival overall. Here you see the curves, and ECMO is the red line, which is above the blue line, which is conventional. These patients apparently weren't super sick, or the doctors across the UK are really good, because those control group centers had an over 50% survival. And the ECMO patients were even higher than that, getting close to 60s or 70s. So interesting, but this provided at least some randomized data, some prospective data that this therapy could be superior to conventional therapy. And then right around the same time, 2009, because of the nature of the Earth, winter comes first in the southern hemisphere compared to the following winter in the northern hemisphere, and influenza A, H1N1, came to Australia and New Zealand before it came to the rest of the world. And doctors in Australia and New Zealand had read Giles Peake studies, had read Robert Bartlett's studies, did a lot of cardiac surgery, and they decided to start using VV ECMO more liberally when there was a new viral condition causing acute ARDS, often, not always, but often in relatively young, healthy people with a good chance for survival. And here's a paper published in JAMA in 2009 showing almost 80% survival for ARDS associated with H1N1, not randomized. This was not there's no control group here, but this is a case series showing that ECMO could have much, much higher survival than it did in the Zapol study and than it had in previous iterations. And this was...
Yeah, so I just wanted to point out what is the uniqueness of this study. Etiology. Single etiology. We never get that in ARDS, right? We don't call them etiology, we call them risk factors for the development of ARDS. They come They are all over, So here, single disease entity. Go ahead, sorry.
Yeah. So, but the combination of the CESAR trial, the Australia, New Zealand evidence, the global variation of H1N1 meant when H1N1 did come to Europe and North America in the subsequent year, there was much more enthusiasm for using VV ECMO, and we used it a lot at University of Michigan that winter. I'm sure many other centers did, and that was the beginning of that uptick in overall ECMO use internationally that you see around 2009, 2010. But we still have to wait many more years until 2018 till you have another ECT. This is the EOLIA trial. Combs is the first investigator, who is French, I believe. And I think he's the one you mentioned. He wrote some articles that you put on the source materials for this conference. And so what EOLIA was a really strictly controlled trial of ECMO versus non-ECMO with specific protocols for how you manage ARDS without ECMO, how you manage ARDS with ECMO, how you manage the blood transfusion, how you manage the ventilator. It went much more into the details than the previous trials had even attempted to do. I'm not going to go through all of those details now because we don't have time, but this is the best level 1 evidence that we have for ECMO versus non-ECMO. And it was international, it was multi-center, it had a larger N, close to 250. There were specific protocols. They encouraged the evidence-based strategies like prone positioning and neuromuscular blockade in the control group. And all that being said, it was stopped early because they could not see a clear difference in mortality despite all those controls. This trial had the opposite problem to CESAR. So CESAR had the problem that patients were randomized to ECMO and they didn't go on ECMO. This trial had the problem that patients were randomized to not ECMO and they still went on ECMO because the doctors felt that they couldn't deprive their patients of that therapy if they were not responding to the conventional treatment, which is understandable. So crossover was an issue. Despite not being significant, there was a numerically lower mortality in the ECMO group than the non-ECMO group, 35 versus 46. So this gets into these issues of if you see a trend, do you take that trend as evidence or do you say it's a trend but it's not significant? I don't. And interestingly, based on their statistical design, this trend was not enough to keep doing the trial. They were told that they had to stop it based on the so far observed lack of difference. Yes, Kapil?
So there was a follow-up of Bayesian analysis. This trial actually, they went ahead back,
Yeah.
did a Bayesian analysis which actually showed beneficial effect of ECMO.
Correct. You're stealing my next slide, so thank you. And in that control group of 125 patients, 35 of them, 28%, crossed over to VV ECMO. So it's not a, sometimes you hear about, there were 3 patients who crossed over. This is almost 30% of the patients crossed over to the other arm of the trial based on the care. And so the treatment failure, which if you're in the ECMO group would be death, if you're in the conventional treatment would be death or crossover to ECMO, was much more likely in the non-ECMO group. And then as Kapil just alluded, this trial has been reanalyzed using a Bayesian framework, and I am not mathematically smart enough to describe Bayesian statistics for you, other than to say the principle of Bayesian statistics is that you don't just look at the trial in a vacuum. You look at the trial in the light of the previous evidence and the pretest probability of outcomes, and you have to make assumptions about what the current base of evidence is and compare it to the new evidence from the trial. And so this is a group, including the main authors of the trial. Combs is the final author. Ewan Golier is from Toronto. He's a pulmonologist. And so this reanalysis suggested that with a variety of initial assumptions, there actually is a relatively high likelihood that ECMO provides a benefit overall compared to non-ECMO in this severe respiratory failure. Basically, the trend towards decreased mortality combined with the Bayesian analysis has led organizations like ATS to put ECMO as a conditional recommendation in their ARDS guidelines. And I don't think, tell me if you feel otherwise, that we're going to see another big trial of ECMO versus non-ECMO at this point. I think we have enough out there suggestive of a benefit. And most surgical therapies like this that are very invasive, you're not going to see a lot of placebo-controlled or trials of doing ECMO versus not, because the equipoise has left the building. And it's made it into, and I think there will be a lot more trials of details of ECMO. How do you manage the ventilator during ECMO? Cannulation strategies, anticoagulation strategies. There will not be trials of doing ECMO versus not doing ECMO for respiratory failure, I predict.
Look at the number of PhDs of them.
Yeah.
And also, remember, we had COVID after this.
Yes.
There's a whole lot of ELSO registry data that we obtained in COVID.
Yeah.
They were not randomized, but it's data, and we have never had that degree of data.
Yeah, and it's very, luckily or not, you had the CESAR trial immediately followed by H1N1, and then you had the EOLIA trial immediately followed by COVID. So the pandemics nicely waited until there was the latest evidence. What's that? Yeah. So COVID, here is the combined ELSO data as of 2021. And so these three graphs are showing sort of phases of COVID. So group A1, I believe, is the purple at the bottom. And basically, these are graphs of mortality. So initially there was pretty low mortality, but then as time went on, group A2, the red one, and group B, the green one, had higher mortality with COVID ARDS. And whether this was because of different variants of the virus or whether this was because of more and more use of ECMO in centers that didn't have as good outcomes, it's hard to say. But there was initially some great enthusiasm with the small centers that adopted early, probably because of a combination of their special expertise combined with patient selection. And then as patient selection got broader, as the pandemic got bigger, the outcomes were not as good overall. But you can see you have as good as a 65% survival in group A and as poor as a 40-45% survival in group B, but still a lot of survival for a condition that was otherwise killing many patients with ARDS, as we all remember. And then specifically at this time, there was a group in Chicago, Rush University Medical Center, who decided that their treatment for COVID-associated ARDS was going to be exclusively VPA version of VV ECMO, giving that right heart support from the beginning rather than waiting to see if those patients develop respiratory failure or not. I would like to think that was because they were really concerned about the risk for RV failure and the possible benefit of this new treatment. You could also make the argument, I think Steve's not here, Steve told me that he has heard that maybe a consideration was that putting in this cannula into the pulmonary artery decreased the recirculation problem, and it made it so you didn't have to spend as much time exposing yourself to COVID in the rooms trying to adjust the cannula after it had been placed. I don't know if that's the whole story or not. But in any case, they adopted across the board VPA ECMO for COVID, and here was their first report of 40 patients and showed a discharge from the hospital of about 3/4 of those patients. So very good early results with VPA ECMO, single center, not controlled, but it caused a lot of attention. They also had a protocol of rapidly getting these patients awake and off the ventilator, mobilized once they had VPA support. They published a larger report in 2021 after 150 patients. That initial really high survival was still good, but not as high as it had been. 67% survival of 136 patients. They were running patients for 48 days, so getting into well over a month, with the majority being extubated and awake during that trial. And enough to have in the ELSO COVID guidelines a note, there may be a role for the use of dual-lumen single cannula right ventricle assist device in patients with COVID pneumonia. However, the evidence is limited. And it's challenging, again, to find the right patient to put this in. Do you do it from the beginning? Do you wait to see if RV failure develops? Do you do it emergently or planned? Still being sorted out. We haven't, at Michigan, we've inherited some of these patients from outlying institutions who already are on VPA ECMO and are transferred for ongoing care to our institution. We have put very few patients on VPA ourselves as of yet, but there is a lot of interest. All right. Thank you very much for your attention. Any additional questions about the studies that I went through there? I know we had a long Q&A session in the middle of my talks. Go ahead. I'd say probably yes. Probably echo can be sufficient if you have good operators. If you have people who have experience, very good experience. I wouldn't say this is for the, the resident, learning, bedside ultrasound for the first time to have the responsibility of directing catheter replacement. But if you have an intensivist or cardiologist with a lot of skill, that certainly can be done. We primarily use fluoroscopy, and sometimes we use simultaneous fluoroscopy and echocardiography. But I don't think anybody yet is doing bedside ultrasound alone.
Dietrich.
Dietrich is? Okay, so one of our...
He's a cardiac surgeon, and he routinely uses cardiac echo to position the camera. So I cannulated with him. I said, show me your technique. He was one of our residents. Now he has cannulated about 500 patients. So he was showing me what he does. So he uses a probe, and he said, okay, that's where the vena cava, that's the right atrium. So he pushes the lower cannula all the way. So sometimes what we will do, we leave the cannula, and then we get an X-ray, and then we gently advance, but you have to be very careful. There are times when we have advanced the catheter blindly, and we are perfect. So yes, there are people who look at cardiac echo bedside. He uses it very regularly. He showed me his technique.
Yeah, and he is a surgeon who, he was at Michigan and he was at University of Maryland for several years.
Yeah.
I think he helped run their ECMO program, did many cases, and now has more recently come back to Michigan. So he has a lot of experience and has developed. So I think, yes, if you have the team, it's not just the cannulator, it's the cannulator and the ICU team.
Yeah.
Working together, it can be done, but I think the fluoroscopy is more established as a position.
And PEE too. We do both. When we are doing it in the cardiac unit, say the big challenge with the dual-lumen part is you put the guide wire. First of all, the guide wire will keep going towards the pulmonary artery. But somehow you have to figure out where the opening will be, and then it will come straight down, right? Once it comes straight down, you are advancing your catheter, but sometimes while you are putting the catheter, you have to be at the right stage where you are taking the guide wire out and the catheter goes into the vena cava. Otherwise, the guide wire out came out a little bit, and next thing you know, this catheter does that. So once it does that, then you are sort of stuck.
Ideally, it should be done in the cath lab or in the no.
Cath lab, they have no availability. They are too busy with their things.
So
if patient is sick, bedside. And we used to do fluoroscopy, but later on we were told in our ICU we have no radiation barriers between rooms, and then somebody did a big deal, and then we stopped doing fluoroscopy. So we routinely just employ plain X-ray. We will measure approximately this is, we use a long cannula, multi-stage, we'll talk a little bit about it. And as long as you are the good part, the ball part, yeah.
Yeah, and so it's OR or interventional radiology is the other option in our institution.
Yes, sir. In that context, if you are going for an ECPR, you can't take a patient up to fluoroscopy.
All right, so ECPR is going to be veno-arterial
How do we know where we are advancing?
X-ray.
X-ray.
Yeah. You can get bedside X-ray, but you can't move that patient anywhere else.
You put a drawing line in and you measure approximately, you will be there. It's not that way. In some ways you have artery and venous, so we don't need that much worry about that. And there are the long stage cannulas.
And you do have to be careful when you have ECPR for cardiac arrest. defining what's the artery and what's the vein is not as easy as you would think, because you don't have the pulsatility, you don't have the color changes, etc.